Good morning, everyone. My name's Kylie Baker and I'm an emergency physician from Ipswich Hospital. And please eat. We're all emergency physicians and we eat while we work. I'm talking on behalf of Fran Kinnear at Prince Charles Hospital, Kath Nizawadi and Georgia Livesey at PA Hospital, and of course us at Ipswich Hospital. I'm always bemused when EMF asks me to talk because I feel like I've got very little to show for myself. I'm sure that I have more rejections than I have submissions at the moment, and sometimes I think the only difference between me and a failure is that I just haven't given up yet. But I've just watched Captain Marvel, and that was a good boost. Anyway, I thought I ought to approach this problem as a researcher and say, well, what is it about my research that EMF values? What is it that they actually want me to tell you to do? That was a different approach. I'll need to start with the background though. I think point-of-care ultrasound is the next zombie apocalypse. There's no doubt in my mind that it's coming to a town near you because we started with really big machines and they've now moved to really small machines that are portable. You can take anywhere on the road, up the mountain to the space station. And they're cheap and they're reliable. And Ellen, we can take them to the nursing homes. And Bill, we can use them in our palliative care all the time. Anyway, off the hobby horse. We have a lot of wonderful papers that with headline-grabbing headlines that point-of-care ultrasound is useful, but we've very, very little about actually implementing it. There's a lot of non-sexy stuff that we're not studying. How much does it cost? How long does it take to implement? What's the skill decay? How long do we have to teach? And that's sort of what we were hoping to address in our paper. We took aim at heart failure because heart failure is very common. We get short of breath patients in the emergency department all the time. And I actually thought that ultrasound would be the answer to our prayers and that we'd be able to replace the chest x-rays with our ultrasounds. But I'm the first to say I was a bit naive when I started. Any rate, what we did was we recruited between the three sites 439 patients who were 60 years and over, who were a little bit short of breath when they came, but were well enough to give consent. So this isn't the most unwell of our patients. About 30% of them ended out having a degree of pulmonary edema. Half of them were randomised to get the normal care. That's the history, examination, blood test, ECG and chest x-ray, and half of them were randomised to get exactly the same thing, history, examination, blood test, chest x-ray, ECG, plus a lung ultrasound. And I thought that I would save the world with this new device. We looked at what the diagnosis was in the emergency department compared to the diagnosis in the at the end of the hospital stay, and we thought if we added the lung ultrasound that we'd improve the diagnostic accuracy. But it wasn't significant. I'll be perfectly honest, we didn't make a big change. And I think lesson number one from EMF, they still like you even when you don't grab the headlines. So long as you're honest about what you come up with, I think research values ambivalent researchers rather than people who are selling a product. That's not enough. We also want to see what actually happened to the patient. Just if I get the diagnosis right, that's nice for me, but it's not necessarily nice for the patient. So we had a look at how long people stayed in the ED, how long they stayed in the hospital. Did they have to come back to the hospital? Did they actually go home to their usual residence? Did they have to go to respite care or interfacility transfers? Did they die in the hospital? And again, we haven't made a significant difference, but by golly, we've got some good baseline figures for anybody who needs them. And I think the second thing that EMF likes is that you try and extend your data to include what actually happens to the patient. Do they actually want what you're giving them? But even that's not enough. You have to look. You can't just start something in the hospital and then assume that it will continue. A one-off release the registrars into the wild isn't necessarily going to implement your intervention. So we saved everybody's scans and we graded everybody's scans, and I can tell you how each individual registrar performed over time, whether they got the hang of it or whether they actually dropped off the radar, whether they knew what to do with the results that they got. That's a whole paper in itself that's still being written. And still, that's not enough. We need to know what this cost the whole system. Is it going to cost the system? How do we convince our administrators to give us a try? We employed a private economics group to look at our data objectively from the outside, and we have now a 60-page grey paper on the individual cost to the individual patients, each individual patient that we recruited. If anybody really needs some nighttime reading, it's available from the EMF. And to cut a long story short, whether it was the big hospital, the medium hospital, or the small hospital, we haven't made a significant difference in the costs, overall cost to the patient or to the hospital. However, I will remind you that we didn't actually remove any tests at all. And I think this is one of those little jigsaw pieces. You have to show that you're not going to cost money before you're allowed to spend money. I've lost a slide, I think. Oh, there we go. We've even got, you can get some amazing data from the hospital computer systems, by the way. You can look at the individual service costs for each patient. So you can find out how much money we spent on our ward services, for how much money we spent on medical services, how much money we spent on imaging services for each of your patients. And interestingly, that tiny little blue stripe down the bottom there is how much we spend on imaging. In retrospect, that's not the target we should be aiming for when we're looking to reduce costs. The big red stripe at the top, I'm sure the nurses will be perfectly aware of this. This is ward costs. This is where we spend our money on our patients. What I would say is we now have this 60 pages worth of this sort of data for you at the EMF. Please use it as a background or a baseline if you want to start some samples and think, or what's the word I'm looking for? Sample size estimates. In summary, I think what EMF likes about our paper, our work, even if it's not the headlines, is that we did recruit enough patients. We're being honest as we can about our results. We've looked and tried to get some patient-centred outcomes, real-world translation, what actually happened when we put it into the wild, and our costs. I hope that we've cut down some of the time to translation.